Welcome to another Inside the Paper episode where we talk to authors directly of articles of significance in endodontics. And today I'm really happy to have a colleague and also a friend, Dr. Josette Camilleri. Professor Camilleri is a professor of endodontics and biomaterial sciences at the University of Birmingham in Birmingham, UK. And we're really happy to have her to talk about a recent paper, which is she published a couple months ago, an updated classification of hydraulic cements used in dentistry. And that's an area that's really close to my heart, obviously. And we would love to have this discussion. Josette, thanks so much for joining.
Thank you very much, Ali. It was a great pleasure. As you say, we have developed a really nice friendship along the years because we have similar specialties and similar interests.
Absolutely. I think people remember us from that famous debate that we had in Montreal AAE, talking about the stuff that later on became kind of pretty common usage. And I think this paper is really about that. That's an updated classification of hydraulic cements. You can't blame us, Dr. Koch, Brave, and myself for calling them bioceramics. You are right about that.
I always put up the slide to blame you.
Absolutely. Make sure you continue to do that. It's not a problem because you are right. We should have called these hydraulic cements. It's not specific enough. And that's part of the reason why we later on developed the term hydraulic condensation for the technique used to use them, because these are hydraulic cements. But before getting into that, let's get into a basic synopsis of your paper. I'm going to leave it up to you instead of me summarizing it.
Okay, so essentially, I needed to make a few points. So I have published first the original classification, which is published in Frontiers. And at the time, as you say, concepts change, people's understanding change. So at the time, I was more concerned with explaining to people, because as you say, everybody called them bioceramics, and I wanted to explain to people exactly the chemistry. So I wanted to make sure that people understood the differences between the material and what was critical. So I came up with the initial classification, which was subdivided into two, looking at the material usage, and the material usage was more about the environment. What does the material come in contact with? So I had that type of classification, and I had the basic chemical classification, which I subdivided into first hydraulic cements, and then I went into hydraulic silicates, hydraulic aluminates. Soon after, we started getting more and more materials on the market. I let it be. You cannot publish updates regularly. It's not easy. It's not easy to publish work anyway, because journals have a high rejection rate, and you don't want to populate the journal with things that are half-baked. Then eventually, I started realizing that a number of these materials actually do not resemble MTA at all. And not only is the environment changing, because the environment changing was actually already in the first part of the classification. We are not sure if the materials are hydrating or not, because most of them, they are dependent on the environment for hydration, but also a number of these materials do not produce the calcium hydroxide. And that really stuck with me, but I didn't know at the time how to explain it, because most of the materials are known as MTA-like. But with MTA, there's always one assumption. MTA is mixed with water. MTA has Portland cement, and Portland cement has a specific chemistry. When it is mixed with water, calcium hydroxide form. And all of everything that happens, biological properties, physical characteristics, antimicrobial characteristics, is all dependent on the calcium hydroxide. Then I asked myself the question, does calcium hydroxide form in every single material, whether it sets or not? And then I realized that I do not know. One, I do not know if the material sets, because I never re-enter to check if the material sets. And secondly, some of the materials have so much in them, because I published a paper with Filippo Cardinali, and we realized that there's a huge diversity. And we weren't sure if actually this calcium hydroxide ever forms. So later on, I convinced myself that I need to rewrite the classification, and I made it a little bit more binary. The classification is there for the clinician to understand and to be able to put the materials that they find on the market into different places depending on what they find. So most clinicians know a bit of chemistry, so they can check if the material is a silicate, produces calcium hydroxide. So that starts with the first bit of the classification, the cement type. The radio-opacifier, the only clinical failures we get is to discoloration. So bismuth oxide based, not bismuth oxide based, again binary. The vehicle, which is important because most of the materials we use are not mixed with water. So whether it is mixed with water or it has an alternative vehicle, again, that is critical because we need to provide this moisture from somewhere. And I can get back to that detail later. And also the additives, because currently people are not really thinking of what the additives are. If you have additives, which are, let's say, calcium aluminates, the calcium aluminate has a separate hydration reaction, but also when it is added to the silicate, the calcium hydroxide is depleted. So it changes the material completely. So I wanted to make this a bit simple, more binary, and easier for the clinician to put the material into different shelves. I have the list of shelves and put the materials there.
Yeah, and I think this is really a brilliant way of breaking it down, because I feel like we discovered in the 1960s that, even probably a little bit earlier, the calcium hydroxide has some special properties. And then we went on to, in the 80s, develop calcium hydroxide sealers. The only problem was that the stuff was way soluble because the vehicle couldn't really retain the calcium hydroxide and the material would resorb out of the area, defeating the purpose. But calcium hydroxide has always been really the important point of it. And so this is really interesting. So we can really think of these calcium silicate cements as vehicles for delivery of calcium hydroxide in a sustainable way. And then you can also understand that if the material ends up either not producing enough calcium hydroxide or the vehicle being inadequate in terms of being able to retain the calcium hydroxide long enough so it doesn't have extra solubility, you are going to have a problem, right?
Yeah, you have put it very elegantly, because you say exactly, it is a vehicle for the calcium hydroxide.
Right.
So the material per se is not useless, but if it doesn't produce this calcium hydroxide, it can be any silicate, because we always say, oh, we need the silicates, large percentages. But if you have an additive where the calcium hydroxide actually never makes it to the area, you have a problem.
Right.
So yes, you have described it very elegantly.
Yeah, I mean, I usually call this a drug delivery device for delivering calcium hydroxide. And that's the key thing, is just that's part of the reason why in vital pulp therapy it's important. And that's why we just can't use calcium hydroxide alone. I mean, we can certainly use calcium hydroxide alone, but the problem only becomes the fact that the calcium hydroxide in vital pulp therapy depletes and you end up left with a little bit of a space. So where these bioceramics come handy is the fact that, that release the calcium hydroxide slowly and you still end up having a filler left behind. So it's interesting, of the multiple bioceramics, and what is the latest count? The last count I had was like 37 or so here in the US, bioceramics. It probably is even more internationally.
There are the packages.
Right.
A number of the labels are just labels, and they are repackaged materials, which a lot of people don't even realize that they're using the same material repackaged by a different company.
Yeah.
But there are more. Definitely.
Yeah, I mean, the manufacturers are probably limited. There's a lot of OEM or, just rebranded material out there. So we established that, it's about the delivery of calcium hydroxide in a controlled manner, in a stable cement that doesn't wash out, doesn't have extra solubility. What do you think are the most egregious problems that you see or run into? A lack of calcium hydroxide are obviously one of them, in which case it completely misses the point, right? So, but what else are you seeing that you think is a problem that needs to be addressed?
Okay, so I think a problem that needs to be addressed is a specific clinical protocol. The big problem is that there are so many of them with so many different chemistries and byproducts. The clinical protocol for MTA has been refined, and things that produce the calcium hydroxide has been refined over the years. We know, because I've done some research myself, but we know that opening up the dentinal tubules by chelation is helpful, because obviously once the dentinal tubules are open, You can get the cemental tags. You also get backflow of the fluids back from the periodontal ligament space, and it is sort of a moisture trap, and everything sets nicely. So those things we know. We need to encourage people to chelate, because I think the key is really the chelation. And we need to watch out again for the different chemistries and the different additives. The biggest problem is how you use them as well. You had mentioned something to me which I didn't forget. Initially, I disagreed, but then I realized you were right. So I have to come clean.
Even a broken clock is right twice a day. So, I mean, I don't take any credit for
I
that.
have to come clean. Because when we did the debate, you mentioned that you insert this syringe only to mid-root. And I was saying, but why does Ali do this? Yes, of course why Ali does this, because Ali has done 1,000,001 cases and you have a problem with extrusion. So I did look into it. We have published a paper again with one of my MSc students in the Journal of Endodontics in January, where we actually look at why these materials extrude. These are fluid lovers. So obviously, unlike the AH, they are not retained within the canal space, because the AH likes the canal because the canal is desiccated. If you leave some moisture and you go very close to the apex, obviously you will get an overfill.
Right.
So I make a distinction between an elegant puff and an overfill. So you can get an overfill. The overfill may set or the overfill may not set. And I did have a couple of discussions with your colleagues in Boston as well, because you do not want something which is extremely alkaline close to the soft tissues, because you will get burns. I know this is not kilos of it, but you will get the burns in the soft tissues. So again, we need to be careful how to apply these materials, the canal wetness, dryness, the removal of the smear plugs, and the little detail to make sure that the material stays within the canal space and we have adequate amounts of this material. Because again, in large amounts, we may get more solubility. If it goes past the apex, you may get macrophage action and other complications which you do not want to.
Yeah, I mean, clearly the goal is to fill inside the canal and seal the canal. These things have absolutely no business outside the root. If they end up incidentally in small volumes, it's insignificant most of the time, because the setting reaction is not bad. It mostly gets buffered in small quantities by the tissues. But absolutely, I mean, you don't want to get a big puff. It's not really indicated. It doesn't look good on the radiograph, nor does it serve any value, right? No, and the funny thing to me is that sometimes it disappoints to see that some of the colleagues don't kind of seem to fully understand the material science and the differences among these different formulations, because these things are biologics, and we all know from chemistry, and even if you have a chiral molecule, just a racemic version of the same molecule would be very different in behavior. So how can you possibly expect different things to be exactly the same? And part of the problem I feel like, or have the same results, and part of the problem I feel like we don't have enough standardization. So thank you for putting together things like this to help categorize these things, because there is no standardization right now. And it's kind of like the Wild West of the wine industry, where, back in the day, right? You could just mix any piece of grape and call it whatever you wanted. But now there is.
Very true.
So it is kind of it's really necessary. So let's get back to formulation differences that make a difference clinically in terms of setting, because that's usually the biggest problem that I hear back from people, that, well, what if the material doesn't set, especially the self-setting materials that don't actually use water? What are the conditions, such as pH or contamination or other things, or even manufacturer problems that could potentially lead to the material not setting in specific situations, or not even biological? Like if you haven't removed adequate amount of the biofilm, the material may not set.
Agreed completely. So I think we need to have an adequate amount of the cement. So what is an adequate amount? Well, nobody knows. However, if people take a bit of baking, people know that if you have too much flour, the material is not going to come together. So very, very low amounts. I mean, again, in the Cardinali and Camilleri article, we've seen that the range of cement ranges from 5% to 50%. I think we need to go to the upper limit, the 50%, even higher. Again, we remember MTA was 80% cement. First and foremost, for the material to actually bind, because the cement is the binder. Secondly, we need to produce this calcium hydroxide. Too many additives. The problem is that people have gone away from the bismuth oxide. So 20% bismuth oxide was enough as a radiopacifier. If you go to low atomic numbers, obviously you need to add more. So you have to compromise. There's so much you can put in a material.
Right.
So my thing will be go for higher cement amounts. The cement is the binder. We need to stop thinking of radio-opacity.
Right.
It is true, you need to see it, but you don't need to go overboard. Especially nowadays where we use the CBCTs, excessive radio-opacity actually is problematic on CBCT because you do not see the rest. This shines through. It is problematic with all X-rays, but mostly also now we're taking practically CBCTs for all the complicated and a lot of more cases because we have the tool, so we have the tool and we use it.
Yeah, that's really a great observation because I feel like historically some of the bigger manufacturers released hydraulic cements that were primarily driven by the old mentality of having a better looking X-ray. And there was a calcium silicate cement, if you will, that was like 70% zirconia. And I was like, how is this even? It's just basically a radio-opacifier with some, biological properties to it. And I feel like our obsession with the radiograph and the look is really holding us back in terms of developing newer products and ideas chemically that could help improve our material properties, but we can't because we have to have that radio opacity. Do you think that is a limitation for us psychologically?
Psychologically, it is a very big limitation because we are always brought up with looking at radiographs, looking at the radio-opacifier. If you cannot see it on the radiograph, it is not there.
Right.
But actually, we need to be looking at healing, better outcomes rather than the radio-opacity.
Yeah, and I say that in my lectures too, Josette, that, manufacturers have caught on to this. And now when you look at these cements, they have so much radio-opacifier. So you can literally just paint one side of the root canal with them, and it looks like you have a perfect fill, whereas like 90% of the canal is empty. It's just, lining one type of the side of the canal. So I think we need to get back into being smarter and think, in terms of the chemistry and the science of what we're trying to do as opposed to the marketing aspect of, putting up a nice X-ray on Instagram, right?
Indeed. I insist the key in successful root canal therapy is not the radio-opacifier. It does have to do with the sealer, but it's mostly the irrigation.
Yeah.
It needs to be proper irrigation, proper chelation.
No, absolutely. I mean, the proper irrigation is the key to success anyway, right? I mean, besides the material science of these things, even though we kind of helped develop these products and had a commercial hand in it for better half, which I, by the way, no longer have. I've kind of retired as of a couple of years ago, no longer have any commercial interest in these products. It seems to me that the research is pretty clear that the success of any particular procedure does not come from any of these specific products per se. It's really a function of your disinfection, case selection, treatment planning, and a number of other factors. And that obturation materials could be equally successful, as you mentioned, in every other case in which you decide to use one technique versus the other. You can have equal success rates because the key is really our irrigation and disinfection protocols.
I have to agree. It's all about irrigation and disinfection. If we want to enhance a little bit, again, in the hands of good clinicians, things work. But then you have more difficult cases. You have people who are not as experienced, who need to be taught the proper techniques.
Right.
So I always say, make sure you use adequate amounts of the hypochlorite, adequate amounts of the chelator. These days, am leaving everything with a final flush of water to ensure that it is the right environment. I dry the canals, but again, people who are less experienced need to follow more the protocols.
Right.
So that is what currently I am working on. I have postdocs, a couple of PhDs who are working on proper protocols as well.
Yeah, I mean, that's going to end up being the critical part of it. Although, to be honest with you, as you mentioned, I've done a lot of cases with this, and since the beginning, since 2007 and 8, where we started doing these, I've always had my final rinse has always been sodium hypochlorite. And I do realize that people want to have water in there as a final rinse, but I after paper point drying it, and then looking at the research, the reality is that sodium hypochlorite, when in contact with dentin, within 3 minutes turns into salt water anyway. Right? So it's not remaining as sodium hypochlorite. So I've always, so I've tried to kind of like bypass that extra step of using another syringe with saline and water in there. So that's been my...
I agree with you. So the hypochlorite is obviously the best to use with things like that are resin-based.
Right.
However, once I was invited to lecture at a restorative dentistry meeting, and somebody commented to me, they asked me the question, I didn't know the reply, but they did comment that leaving behind salt crystals, in fact, this person said, do not rinse with saline. It may interfere with some of the settings for posts. Because as you know, people may drill the GP out, and if there are salts in the dentinal tubules, and they try to bond with some resin systems, the chloride may affect the bonding. So that is from the restorative perspective, rather than from an endodontic perspective and microbiology.
That's a valid point on the post side, but provided that they're not going to use a post drill, right? Because if they use a post drill, that'll basically remove everything, and they're going to essentially have to etch and bond anyway. I mean, the etching part will wash out any potential particles, right? Because if you're going to be etching in there, you're going to be washing it anyway. But you're right. I mean, there's a lot of nuance in this. I always say in my talks is that creating these very complex chemical materials, these biomaterials, it's kind of like making a bowl of chili, right? Everybody has their own formula, but there is just the right amount of something that makes it a chili, right? It can't be all beans, it won't be chili. It can't be all pepper, it won't be chili. But you just have to have the right balance of things for it to work and be palatable. But there's multiple ways of getting a chili recipe. So, Dr. Camilleri, is there anything we should talk about that we're not talking about when it comes to these calcium silicate cements before we end this episode?
Well, I think this has been a comprehensive overview. I've explained the classification. You have asked me very pertinent questions. And what I encourage people to do is to read. I always tell people, you have to continue to pursue education. Whenever you have graduated, the reading is important, listening, going to conferences is important. There is a lot on the internet. You are one of the very good providers of insightful things on the internet. And be critical. One has to be critical. One cannot believe all one hears.
That's right.
Which is important. So continuous education and reading and analyzing that there are various products on the market. One needs to check that there is literature on the product, check it out, try a few cases, get the recalls, not embark on, I use only this because this works in my hand, and using materials appropriately.
Yeah.
That is the only thing I can recommend. Very, very important to follow the manufacturer's instructions.
Really insightful feedback from a material scientist, really paying attention to that chemistry and the exactness of the importance of the instructions. So thank you so much for joining me, and we hope to have you back again with more of your interesting papers being published, and we can chat about those.
I'll do my best, Ali. It was really good to meet you. Thank you very much.
Thank you. We hope you enjoyed this episode of the Inside the Paper, and we'll see you in the next episode.